Okay, welcome back. Now we're going to talk about exciting themes, rheobase and chronaxy. So rheobase is basically the measure of the current amplitude or intensity, the minimum current amplitude with a very long pulse duration required to produce an action potential. Chronaxy is a measure of time or duration, which is the minimum duration it takes to stimulate tissue at twice rheobase or twice the amplitude. So it's just terminology to describe different ways of getting that action potential. I wouldn't worry about that a whole lot, just to know that those are terminologies that used to describe it. Okay. Accommodation. This would be, the definition would be a current amplitude must rise quickly for an action potential to be triggered. If the current rises too slowly, the nerve will accommodate to the stimulus. Process of a nerve gradually becoming less responsive to the stimulation. This occurs with a slow rate of current rise because of prolonged subthreshold stimulation. So when we get to start talking about TINS, we'll talk a little bit more about this accommodation factor and what happens with being at that subthreshold level and why it's important to try and get your patient to that desired response that you want with the action potential in order for you to get the benefit of the electrical stimulation. Propagation basically just means the movement of that action potential on the neuron. If you can remember back from your physics, you have the nodes of Ranvier. So you have, once an action potential is generated, it triggers an action potential in the adjacent area of a nerve membrane. Usually moves in one direction. We've already talked about this, that the speed is determined by the size or the diameter of that nerve and whether it's myelinated or unmyelinated. And we know the fastest ones are those large diameter myelinated nerves, and the slowest ones are the smaller unmyelinated nerves. A saltatory conduction, that's the action potential is propagated along that myelinated nerve fiber jumping from those nodes of Ranvier. Muscle depolarization. When you have a denervated muscle, it can only contract in response to pulses greater than 10 milliseconds. So this is why it's a little bit more painful. We call this electrical muscle stimulation versus the NMES, and that's just the differentiation between the two, just because you have a denervated muscle, so that we eliminate that neuromuscular part on the NMES. So with a muscle that is denervated, we use electrical muscle stimulation. Okay. The ionic effects of electrical currents, as we looked at, usually it's a balanced biphasic waveform that leaves no charge in the tissue, and you don't have any ionic effect. With the direct current, also known as DC current, it's a pulse monophasic current. Unbalanced biphasic waveforms do leave a net charge in the tissue, and it can produce an ionic effect. So if you look in your book and also in your lab packet, you have different waveforms, and there's some worksheets in there that you'll probably do in your lab class that will help you to understand the different waveforms, and I would encourage you to look at those. A cathode is that negative electrode attracts the positive charged ions and repels the negative charged ions. An anoid is the positive electrode attracts a negative charged ions and repels positive charged ions. So basically a cathode is a negative electrode and it will repel the same negative ion, and an anode is a positive electrode and it's going to repel those positive charged ions. So we use this principle when we're talking about iontophoresis. When we're trying to drive a medication into a tissue, it's important for us to know the polarity of the medication that we're using and also the pad that we're using. So the ionic effects of electricity used to treat inflammatory states facilitates tissue healing and reduces that formation of edema. We also can use electrical stimulation on motor points, and these motor points are locations on skin where the electrical stimulation most effectively causes specific muscle contraction. And again, we have a lab scenario where you'll get to try this with your patients, and we have different motor point charts that you can look at. So with the quadriceps, there's certain areas on the quadriceps where you have these motor points, which will be a little bit more effective to get a muscle contraction where you don't have to turn the amplitude up as much, and it'll be more effective. So we'll kind of play around with that a little bit. It's pretty fun to do that. Clinical applications, we talked about this at the beginning. We can use it for muscle strengthening as well as muscle re-education. We can use it for pain control and all the different phases of the healing process, acute, subacute, and chronic pain. We can use it to facilitate healing of recalcitrant wounds, resolving edema and inflammatory reactions after injury or surgery, and also to enhance transdermal drug delivery, also known as iontophoresis. So here's just a review of the gait control theory. You have your A delta and C fibers, those nociceptive fibers, and then we have the A beta fibers, which are the non-nociceptive fibers. You have the inhibitory interneuron, and then it goes up, and remember we call this the ascending pathway. And remember that the A beta are those larger myelinated, so they're going to go faster and they're going to get up here a little bit sooner than the non-myelinated. The C fiber and the A delta fibers is going to get there faster than them, and it's going to close that gate up there to close that perception of pain. And so I was just talking here about that balance of the excitatory and inhibitory inputs to this T cells in the spinal cord. And we're talking about E-stim can control that pain by activating those non-nociceptor sensory nerves, which inhibit activation of the pain transmission cells and close the gate, which decreases the sensation of pain. So we just have to realize with this, it depends on the type of electrical stimulation and the parameters that we use. So this would make sense if we're using E-stim in a sensory mode. Contraindications: pacemaker, cardiac arrhythmia, the anterior neck, cancer, thrombophlebitis, decreased sensation in the area to be treated, infection, pregnant, low back, abdomen, and trunk. And there is a disqualifier here. They do use TIN sometimes during labor and delivery, and you can read about that in Cameron, for skin lesions. And these contraindications are the same ones that are on your practical exam rubric. There are a few added ones here than are in your book, but just know that you'll be responsible for these contraindications. Precautions: cardiac disease, patients with impaired mentation, areas of skin irritation or open wounds, and iontophoresis after other physical agents. So we really want to realize with iontophoresis, if you've used ultrasound, where you've vasodilated, or cold therapy where you're vasoconstricted, you might want to be cautious of whether or not it's appropriate to use that medication at that point in time. Adverse effects are birds, so we always want to let our patients know it should just feel comfortable, that they don't want to have any unusual, uncomfortable sensations. You're always going to check the skin afterwards. Oftentimes patients can be allergic to the gel or the self-gel material of the electrodes, and so you have to double check on those. They might just not like it. They may find E-stim is uncomfortable for them, so that's more that hyperesthesia person, that it's just an uncomfortable sensation for them, so you're going to choose a different type of modality for them after you've tried changing the settings for them and it still feels painful to them. Documentation, so we're always, again, going to the area of the body we treated with the electrical stim. What position did we put that patient in? The parameters, the electrode placement, the treatment duration, and the response to treatment. And under parameters, that's where you're going to do the pulse width or the pulse duration, the intensity, the amplitude, how far away did you put those pads, where did you place those pads. Those are all part of your documentation so someone can replicate your treatment. And that's it. Thank you.